today's presenter. Dr. Rebecca Kruse-Jarres received an MD from Tulane University School of Medicine and an MPH from the Tulane School of Public Health and Tropical Medicine in 1999. Following that, she did her internship and residency in internal medicine from 1999 to 2002 and a fellowship in hematology oncology from 2002 to 2005 at Tulane. She was hired as an assistant professor in 2005 at Tulane and became the associate director of the Sickle Cell Center of Southern Louisiana in 2006. Dr. Kruse-Jarres is the director of the adult program as well as the Sickle Cell Day Hospital. So I would like to greatly thank Dr. Kruse-Jarres for joining us today, and I would like to ask you, Dr. Kruse-Jarres, to please unmute your phone at this time by pressing *6 to address the audience. I will turn the phone over to you. Thank you.
Wonderful. Well, thank you so much for having me. And I will be talking about transfusion issues for sickle cell disease and thalassemia patients. And thank you for the kind introduction. And in the introduction, you mentioned I'm coming from an adult background. So this is going to be a little adult-tainted, but I also have a clinic over with a pediatric treater. So I'm trying to kind of cover both here. I don't have any pertinent disclosures. Can I have the next slide? Hello? Can I have the next slide? There we go. So what I do not want to do is to repeat a very excellent lecture that was given in March of 2011. So I'm going to talk about some other issues, but I will come back to iron overload towards the end of my talk because I think it's very important when we're talking. We cannot talk about transfusion without talking about iron overload. Next slide. So what I want to do in the next 40 or 45 minutes is I want to give you the evidence that's out there for indications for acute and chronic transfusion. And then I want to go into some complications from chronic transfusion, such as access, infectious risks. We're going to be talking about immune response, and we're definitely going to be talking a little bit about iron overload towards the end of the talk. Next slide. So first we have to ask ourselves, and that is very, very important, what is the goal of the transfusion? And I really am known as the transfusion Nazi around here because all my patients will not let internal medicine doctors that are taking care of them transfuse them because they say, oh, you have to talk to Dr. Kruse-Jarres first. Because I started seeing that my patients are getting transfused for anemia alone, and that is not an indication. Patients should be treated as patients by symptoms and certainly not by a number. So if they're symptomatic from their anemia, yes, then I think that's a goal to raise the number some. But let's not just look at a number of hemoglobin of 6 and say we need to transfuse the patient. So beyond that, the goals of transfusion need to be to lower the hemoglobin S. We know that sickle cell-rich blood is more viscous, and we know that sickle cells have a reduced lifespan. So we can reduce the viscosity by transfusion, and we can prolong that lifespan. And that might be very important because we may be able to reduce the erythrocyte production. And we know that in sickle cell we have this phenotype of a hyperhemolyzer, and those are people that turn over their bone marrow rather rapidly. And I think these are people where we have to say, well, can we slow down this turnover of the bone marrow by transfusing them some? I don't think that we have the answers to that yet, but that could certainly be one of the indications. Can I have the next slide? There was a wonderful summary of indications for transfusion therapy in sickle cell disease. This is a little bit of a busy slide, but it comes from this publication from 2009. And some of these claims do have evidence, and I'm going to go through some of the studies. But just to introduce you to it, in the first column on the left, we have indications for acute transfusion. And that may be something like acute chest syndrome and clinical stroke. I think nobody would debate with us that these people should be transfused. Then there's the question of preparation for major surgery, and I'm going to show you the study that led to the transfusion recommendation. In acute splenic and hepatic sequestration as well as aplastic episodes, we certainly want to transfuse. Then there's the question about acute multi-organ failure, and I'm going to show you some data on that. In the chronic transfusions, we have very solid data that stroke and abnormal TCD should be transfused. Pulmonary hypertension, maybe less so, but that's something that we're starting to look into. Recurrent sequestration crisis in young children awaiting surgery, certainly we should think about chronically transfusing them. And then people who have symptomatic anemia associated with chronic renal failure or congestive heart failure, may they benefit from chronic transfusions. And then there are a lot of controversial areas where we really don't know yet. I'm going to show you some data on pregnancy. What should we do with people with abnormal neurocognitive testing that have a normal MRI, or people with severe growth retardation, renal insufficiency, ophthalmologic complications. I'm going to show you a little bit of data on acute and chronic pain, and it's also controversial whether transfusion plays a role in priapism. Can I have the next slide? So we know that stroke is one of the indications, and just to get everybody up to date, this is the most solid data we have in sickle cell disease, and I think it's worth us reviewing it here. On the left-hand side, you see that patients with sickle cell by genotype are more likely to have strokes, and they have these strokes at a young age. And on the left-hand side, you see that people with hemoglobin SS disease are more likely to have a stroke than people with SC or with an S-beta thalassemic component. On the right-hand side, you see in the dark line, those are the ischemic strokes, and the dotted line, those are hemorrhagic strokes. So children at a very young age are likely to have an ischemic stroke. Then that incidence or risk goes down when they go into their 20s and 30s, and they're more likely to have a hemorrhagic stroke during that age. And then later, as they get older, they're more likely to have another ischemic stroke. And I'll mention the guess that those ischemic strokes are probably more normal age-related occurrences, and they may not really have the same predictors as the ones that have strokes during childhood, but we don't know that for sure. So when we're talking about stroke prevention with transfusion, we're talking about ischemic strokes and not hemorrhagic strokes. Can I have the next slide? Very important study published in 1997 was showing that increased velocity on transcranial Dopplers was a risk factor or predictor for people having a stroke. And here you see in the solid line, those are the people that have transcranial velocities of more than 200 centimeters per second, and they're more likely to have a stroke than people who have less velocity. Next slide. Based on that study, that was the basis for the study that became known as the STOP-1 trial, where 130 children were randomized to either receive transfusion versus standard care. And you see on the left-hand side the primary outcome, which was in the transfusion arm, which is the top arm. Those people stayed event-free, where the standard of care arm had significantly more events, and that was statistically significant. So since then, we have started patients not only screening children with transcranial Dopplers, but patients are placed on chronic transfusion if they have abnormal Dopplers. On the right-hand side, you see a longer-term follow-up. This stayed true even when patients were followed up longer than the initial study. The next slide. These people that we have now committed to chronic transfusion or exchange transfusion, can we take them off this eventually? And that led to the STOP-2 trial, which was a study that was stopped early after 79 patients of 100 planned enrolled patients. So half of the patients were taking off transfusion protocol, and the other half were continued on transfusion protocol. And it was very clearly seen that the patients, as soon as we got them off the transfusions, the transcranial Dopplers went up, and they were more likely to have another neurologic event. So based on that, and this is what we're stuck with at this point, once a patient is on a transfusion protocol, for either an abnormal transcranial Doppler or a stroke, they're going to stay on that. And the question is, how often do we have to transfuse them? Do we really have to do it like most people probably do, every 4 weeks, or can we stretch it out to every 6, to every 8? And we're currently conducting a study here where we're looking at adults and at their transcranial Dopplers to see whether that could be a predictor, whether, how often somebody needs to be transfused. Can I have the next slide? So beyond avert events, they also, during the STOP-2 trial, looked at the occurrence of silent strokes. And you have in the group 1, you have the patients that continue transfusions, and group 2, where the transfusion was halted. And at the entry of studies, some of them had silent infarcts and some of them had normal MRIs. And they showed at the study end that in the group where transfusion was continued, there were overall fewer new lesions in both the people that started with silent infarcts as well as the ones that had normal MRIs than the ones where the transfusion was halted. So based on that, we have even more evidence that stopping transfusion is really not a good thing to do. Next slide. So let's leave stroke and let's look at acute chest syndrome. There was a study of 537 patients in 30 centers, a very large endeavor that was done with the National Acute Chest Syndrome Study Group. Acute chest syndrome was defined as a new infiltration consistent with consolidation and at least segmental in size, and it had to be accompanied at least by either chest pain or a temperature over 38.5 or tachypnea, wheezing, or cough. And this study clearly showed that patients that were transfused for acute chest syndrome had overall fewer hospital days, had less respiratory failure, and fewer neurologic complications. So if somebody has acute chest syndrome, they certainly should be transfused or exchange transfused. Next slide. Question is, can we prevent acute chest syndrome? And this is just a pilot study, but I think an important one. This study was done because previously it had been shown that secretory phospholipase A2 was a predictor of somebody having acute chest syndrome. So they had a small pilot study where these high-risk patients were randomized to either receive standard care or a simple transfusion. And the people that received a simple transfusion, out of that arm, out of those 7 people, nobody developed acute chest syndrome. And in the other group, 5 out of 8 did. So this is very statistically significant. And though pilot data is definitely something that we should think about when a patient comes in just regular vaso-occlusive episode, but has this high-risk factor, should we really jump to transfusion earlier? Next slide. Multi-organ failure was assessed also in a very small study, and unfortunately for most in adult sickle cell disease, we have only case reports or small studies. So this is one of them, and it was published a long time ago, but they were worried that multi-organ failure was brought on by viscosity, and they suggested that transfusion would help. So they transfused 14 patients in 17 episodes with aggressive transfusion, and the survival was 94% in the transfused patients. So I certainly think that if somebody has multi-organ failure, we should transfuse or exchange transfuse a person. Next. Preoperatively, the question became, or it was seen that people were doing better, and it makes a lot of sense to transfuse somebody before they were going to a cold OR. It's a very stressful environment, and patients are likely to run into complications. The question became, should we do a simple transfusion or should we do aggressive transfusion with something like an exchange transfusion? So patients were randomized to 2 groups, and this was really a significant number of patients. 303 patients were randomized to get an aggressive transfusion with a goal of a pre-op hemoglobin S of less than 31%. And the group 2 was 301 patients that were conservatively managed with just a regular transfusion. So their overall pre-op hemoglobin S was much higher at 59%. What is really important and what I want to point out here is, of course, the patients in the first group overall had a lot higher number of units transfused to them than the conservative group. But very importantly, this study that we are basing our clinical practice on was a largely pediatric study. As you see here in the first line on age, most of the patients were between 0 and 19 years old. There were some adult patients in the study, but they were by no means the majority. Next slide. So, and then it is important to know about the study what surgeries were done or observed. And the majority of surgeries were cholecystectomy or ear, nose, and throat procedures. So what we would consider relatively minor procedures. There were some orthopedic procedures on this study, but I'm always getting asked because I still do exchange transfusions with my patients before an orthopedic surgery because that's a much longer procedure than a cholecystectomy or ear, nose, or throat. Next slide. So what they showed is that the group 1 and group 2, so these are the exchange transfused patients versus the simple transfusion patients, they had a similar rate of complications. So based on the study, it was said that, well, if you simple transfuse a patient to a hemoglobin of 10, that is equivalent to an exchange transfusion. And I definitely think that is true in pediatric patients who are getting a cholecystectomy, but I don't really know that we know what to do with an adult patient who is going to undergo a more rigorous procedure such as an orthopedic, like a hip replacement. Next slide. Prophylactic red cell transfusion was also tested in patients who were pregnant to see whether the pregnancy complications could be lessened. This was a study in 72 patients, and I apologize, again, an older study, but I think worth reviewing. Patients either got prophylactic transfusions versus on-demand. And overall, it was found that there was no significant difference in perinatal outcomes of the offspring. It was shown that prophylactic transfusions significantly reduced the incidence of painful crisis, and that makes sense. Not statistically significant was the cumulative incidence of other complications of this disorder, and there seemed to be no difference in sickle cell unrelated complications. So based on that, I would not routinely transfuse a pregnant patient. Next slide. But the question was raised that, well, can we decrease pain with chronic transfusions? And this is data from a sub-analysis from the STOP trial that randomized people to either receive transfusion or observation. And it was clearly shown with statistically significant p-values that acute chest syndrome as well as pain was markedly reduced in the transfused arm over the observation arm. Next slide. So beyond that, we have to ask ourselves, can we prevent pain and acute chest syndrome, and especially in adults, that's very alluring. I have a lot of patients with chronic pain, patients that are utilizing a lot. They're in the hospital at least once a week, or they're in the Sickle Cell Day Hospital several times a week. And the question is, can I go ahead and put them on an exchange transfusion protocol or transfusion protocol and decrease the utilization and make things better? This is, again, a very small study. This is only in 6 patients. But it was shown that if people were put on exchange transfusions, they had overall fewer pain crises and fewer acute chest syndromes. So this might be something that we want to consider in our very difficult patients that seem to utilize a lot and seem to have a lot of pain. Next slide. Other possible indications for transfusion could be what I alluded to before in this hyperhemolysis syndrome, which often is associated with pulmonary hypertension, priapism, and leg ulcers. There's a complete lack of randomized trials, however. Next slide. Before we're going to complications, I do want to draw your attention to the recently or last year published guidelines of the use of therapeutic apheresis in clinical practice. This is a group that sat together and said, well, in acute chest syndrome, acute stroke, and as a prophylaxis for primary, secondary stroke in an attempt to reduce transfusional iron overload or in multi-organ failure, what do we do and what should be the evidence that we use apheresis in these patients, or red cell transfusion? And as you can see in the top table, there are no randomized control trials or control trials for any of them. There are some case series and some case reports, and based on that, we have some recommendation, and the recommendation great for acute stroke, acute chest syndrome, and switching to apheresis over regular transfusion to prevent iron overload. They have pretty strong, great recommendations. With multi-organ failure, because we have so little data, the recommendation is not as strong. Next slide, or next slide. So with that, I want to leave the indications, and I want to talk for the rest of the time I want to talk about complications of chronic transfusions. Next slide. This is kind of a summary of what we were going to go over in the next few minutes. Obviously, there's always going to be administrative error, and I'm not going to go into it any more than this, but it's something that we certainly need to be aware of. Whenever we give somebody a transfusion, there's the potential of an administrative error. Then we have IV access-related complications. I'm going to go a little into that. We're going to talk about volume overload and hyperviscosity, then infectious risks. I'm going to talk more about immune reactions. We're going to talk about alloimmunization and delayed transfusion reactions, which can be very detrimental. And I'm going to end up on iron overload. Next slide. So first, the access. Certainly, whenever we can, peripheral access is preferred. But as all of us know, it can be very, very difficult. And I have some patients that come to the Sickle Cell Day Hospital often, and even anesthesia after 6 and 7 trials will not be able to place a peripheral IV. So these are people that probably should be considered for a central access. And the central access can be, in most of our patients, probably is a portacath. If I have patients on exchange transfusions, we place a double lumen vortex portacath, and I have very good experiences with that. With all of them, however, you can have an infectious risk or a thrombotic risk. But in my experience and some case series, as well as talking to other colleagues, it seems like there are a few patients that are the ones that with recurrent infections and thrombotic events, and a lot of patients do quite well with their portacaths for a long time. I have a couple of patients where I just place Quinton catheters for their exchange transfusions because they've had many infections and thrombotic events with portacaths in the past. Very interestingly, and this is just some emerging data, some centers seem to have good experiences with arteriovenous fistulas. You see one here in the picture. Next slide. Volume overload and hyperviscosity has to be on our mind when we transfuse a patient. And I alluded to that in the beginning. Let's not transfuse our patient because our patient is anemic. This is a physiological adaptation. I have patients that their baseline hemoglobin is 6 to 7, and that's what they're always going to be. They're not symptomatic. If they're dropping to hemoglobin of 5, there's absolutely no indication to transfuse them unless they're symptomatic. Aggressive transfusion in these patients can result in volume overload and hyperviscosity, and that has been shown to lead to congestive heart failure, pulmonary edema, and CNS events. So we really want to prevent that. And I talk to our residents and interns a lot, and to my primary care colleagues to not transfuse patients if it's not indicated. Next slide. We all know about the horrific complications, infectious complications that we had with blood transfusions of hepatitis and HIV. Fortunately, this is not something that we see much or that I really have seen over the last decade anymore at all. But there was a time in the 1970s when probably 30% of our donors were infected. That with good testing and donor screening has really gone down to pretty much zero. But what I want to illustrate with this slide is that I still have newly referred adult patients that are coming to me, and nobody has ever bothered to screen them for hepatitis C. I'm still picking up patients that have been infected with hepatitis C probably a long, long time ago from a blood transfusion. If we don't look, we're not going to see it, but I think these patients deserve to be identified and deserve to be offered treatment. Next slide. With nucleic acid testing, our blood supply has become much, much safer. We're screening for HIV, hepatitis C, West Nile virus, human T and lymphotrophic virus, hepatitis B. But the next infectious agent is going to be around the corner. I don't know what it's going to be. Nobody knows what it's going to be, but I think we need to be aware. It's not like we're pasteurizing our blood. So it is going to manifest, and it's going to manifest in patients that are getting a lot of blood transfusions, and that's going to be our population. And I also want to talk, 0.2% of the blood is infected with bacteria, so that is something that can happen in anybody, even if they've been screened. Next slide. Let's switch to immune-mediated complications of transfusion. One of the emerging things is transfusion-related acute lung injury. It's been identified since 1957 and certainly was better defined in the 1980s, and we're more aware of it now. According to the FDA, it is the most frequent cause of transfusion-related mortality reported, and that is up to 15%. It happens in 1 of 5,000 blood components transfused, but if we're thinking about how much we're transfusing, we are bound to see this. It is antibody-mediated, and that can be against HLA antibodies, or it can be granulocyte-specific antibodies, monocyte-specific IgG. But if we have a patient who after a transfusion develops a fever, hypotension, respiratory distress, bilateral pulmonary infiltrates, and transient leukopenia, I think we need to think about transfusion-related acute lung injury. It is probably underreported, especially since these might be some symptoms that our patients have to begin with. Next slide. Graft versus host disease is very, very rare, but it can be deadly, and it certainly can happen in our patients. This presents with fever and rash. It can be some GI side effects, such as diarrhea, nausea, vomiting. It can be a cough. Usually if they have a rash, that can be biopsied, and the diagnosis can be made that way. Unfortunately, this is usually almost fatal. There is no effective treatment. It can be prevented by irradiating blood, which we don't routinely do in sickle cell patients, and I think if the patient is immunocompetent, I would not recommend doing that, but I certainly recommend leukodepletion with filters in all of our patients. Next slide. Alloimmunization, on the other hand, is much, much more common. The cooperative study of sickle cell disease looked in 1,814 patients with sickle cell disease that had been transfused, and the overall rate of alloimmunization was 18.6%. That is a very, very, very significant number. And if you look at the graph on the right side, they kind of looked at that by men versus women and what age groups. And as you can see, the darker marks are men and the open circles and squares are women. So women, especially in their, above 20 years of age, are much, much more likely to get one of these alloimmunizations over men. And I tend to see that in women who are pregnant and are getting transfusions during pregnancy, so it's something to be aware of. In the STOP1 trial, they looked at alloimmunization. They found that 16% of the transfusions had to be discontinued because of alloimmunization. Matching for C, E, and K antigens decreases the rate, and I'm going to show you some data on that in a couple of slides. Next slide. Exchange versus simple transfusion. Oh, and that's misspelled. I'm sorry. This was in the preoperative study or perioperative study that I quoted before, where they looked at exchange transfusion or simple transfusion before an operation. And they looked at new alloantibody development. And as you can see here in the first line, the group 1, which was the exchange transfusion group, had significantly higher alloantibody development than group 2. Next slide. So with that, I want to illustrate this on how difficult this alloimmunization can be. I want to talk about a case I had. This is a 26-year-old lady with hemoglobin SF disease, very active, who had some avascular necrosis, otherwise relatively rarely has pain, is doing pretty well. She had a severe transfusion reaction in 2006 before I actually took care of her, and it's not quite clear to me what happened to her then, but she received IVIG, and it seems like she responded to that really well. Then she was doing well for about 3 years, and then received 2 units of blood while undergoing C-section for her first pregnancy. She was doing fine with that, went home, and 5 days later presented with profound shortness of breath and markedly decreased hemoglobin to 5.3. She was admitted to internal medicine, and they gave her another 2 units of blood. She became increasingly symptomatic, and her hemoglobin dropped to 3.2 by the next morning. At that point, they called me. We gave her IVIG and steroids, and nothing. She didn't respond to anything. So she was in the ICU. She was on a non-rebreather, oxygen mask for several days. She received symptomatic care. I was very scared to give her any further blood, and she eventually recovered on her own. Now, this lady did well for about a year, and then she was knocking at my door because of her now very severe avascular necrosis that was impairing her life, and she could not get around. She could not really take care of her daughter, and she was begging me for a hip replacement. And I said, listen, I cannot give you blood transfusions. I don't know what I'm going to do. I think this is not a safe procedure, but she continued to beg me to do that. Her hemoglobin at that point was 6.4. So the question became, what do we do? Next slide. So this lady clearly had a case of delayed hyperhemolytic transfusion reaction, and if you've ever had one, they're scary, scary. Here is a very nice summary of case series of delayed hyperhemolytic transfusion reactions, and as you can see here in the third column, they occurred anywhere between 2 and 19 days after the transfusion. Some of them had previous antibodies, some of them did not. Some of them developed new antibodies, and some of them did not. So it's really difficult to predict who's going to be having this delayed hyperhemolytic transfusion reaction, but certainly if somebody has had it once, they would be at extremely high risk to have it again. So the question became, what do I do with this lady that will do anything and will die just to get rid of her pain in her hip? Next slide. So what I decided to do, and this is completely off-label, I decided to give her an anti-CD20 agent, that is rituximab, and I gave it to her for 4 weekly doses, just in an attempt to reduce her response. And this is not something that's ever been widely studied, but there are a couple of case reports out there. So I gave that to her prior to her left hip replacement in May 2010. She went into the surgery with a hemoglobin of 6.4. Her nadir after was 5.1. She was not symptomatic, and she spontaneously recovered without any blood transfusions whatsoever. She then, a year later, came back to me and now wanted to have the other hip done. That very severely impacted her or affected her life. and we decided to do it again after very thorough discussion with her and consenting and documenting. She this time went into the surgery with a pre-hemoglobin of 5.7 and had a nadir of 5, and again spontaneously recovered without ever needing any blood transfusions, and she's doing very well. Now, I'm not telling you to do this at home, but this was a way I never had to give her any blood transfusions. I have no idea whether if I would have challenged her, whether she would have had another transfusion reaction, but it was my safety net. But as you can probably imagine, this caused a lot of sleepless nights, I assume on my patient support, but certainly on mine. Next slide. The question is, what can we do to even prevent these delayed hyperhemolytic or any kind of hemolytic transfusion reactions that are immune-mediated? And antigen matching is emerging as one of the things that we really need to pay some attention to and that we need to discuss as a group. On the top here are some studies that looked at the rate of alloimmunization if you just do matching in ABO and D only. And those rates were anywhere from 34%, 18 to 31%, 30%, 29 to 35%, to be expected. Then in the middle here, you see the matching extended when the matching was extended beyond ABO and D and included C, E, and K antibodies. And when you do that, you see less of an alloimmunization. So this was, in this case, 8 to 11% or 5%. And more recently, there's a group, and there are actually a couple of groups that have extended the matching beyond even that and do further matching, and they so far are showing that they're not having any alloimmunization. It is very expensive to do this very extended matching, but I think it's something that we need to consider if we can prevent the cost of screening later on, because it becomes very difficult to find matched blood in people who have multiple antibodies. With that, I am going to switch to iron overload. Can we have the next slide? So iron overload, as per the STOP1 trial, it was shown that the transfusion arm, their ferritin rose by 1,500% over the first 24 months. Usually we get about 10 to 20 milligrams of iron in our diet, and we only absorb about 1 to 2 milligrams of iron a day. That's then transported by transferrin. Most of that is incorporated into hemoglobin as part of the erythropoiesis. We also have some in myoglobin. And the rest of it is stored in ferritin. From there, it gets stored in the liver, in the heart, and the endocrine organs if that becomes too much. And then we only lose about 1 to 2 milligrams a day. So you can see if I give somebody a blood transfusion, I give them all these red cells, they are going to contain a lot of iron, and that iron has to go somewhere, and it's not going to be eliminated from the body easily. So this is clearly what's leading to iron overload in these patients. Next slide. And that there's a relationship of liver iron to duration of chronic transfusion is illustrated here in the slide, where liver biopsies were done to determine the dry weight and iron overload, and that correlated to the months of transfusion. Next slide. And this was done actually despite this. I don't know where it disappeared, but this data is in spite of good iron chelation. Next slide. So why am I bringing up iron overload again? We talked about it in March, but why is it so important, especially in the adult patient? And here's another case to illustrate that. This is a 36-year-old gentleman with hemoglobin SS disease. He had a stroke when he was 4 years old and had been first on transfusion and then on exchange transfusions every 3 to 4 weeks for many, many years. He had a wonderful mother who took care of him. He had some neurologic deficits, but with taken care of, and she brought him regularly. And it seemed like when he would go with the exchange transfusion only every 4 weeks, his hemoglobin S would go up to over 40%, and at that point he would have more neurologic symptoms. So he received his exchange transfusions probably overall a little more often than some of my other patients. Well, over time, he developed profound iron overload, and that was confirmed on liver biopsy. His ferritin continued to be over 5,000. He, and I am convinced, was very compliant with the Firazerox at 40 milligrams per kilogram daily. But despite that, he had increasing signs of liver failure, and eventually, unfortunately, his liver failed, and he did die of liver failure. This is not the only patient I've lost to liver failure, and there are more to follow if we're not careful about iron overload and take this very, very seriously. Next slide. Iron overload in sickle cell disease appears to be different from thalassemia, and it has been shown, and I'm kind of mentioning different studies here, but they're at similar ferritins and similar iron load by biopsy in the liver. There seems to be more fibrosis in people with thalassemia. There's also significantly more endocrine and cardiac involvement. However, the mortality is significantly higher in sickle cell disease. Now, that might not be due to the iron overload, but rather the sickle cell disease itself. Next slide. Here's a study in 73 patients that received chronic transfusions that compared sickle cell disease or thalassemia in the first column and sickle cell disease in the second column. These were patients that were relatively age-matched. The duration of transfusion was longer in the beta thalassemia group for probably obvious reasons. The serum ferritin was a little bit higher in the sickle cell group. The iron liver concentration, however, the liver iron concentration, however, was comparable in both groups. Now, if you're looking at the organ dysfunction, there was no cardiac dysfunction in the sickle cell group. There was also no endocrine disease in the sickle cell group. So this seems to be something that happens in thalassemia over sickle cell disease. And overall, if you're looking at the abnormal fibrosis score all the way at the bottom, that was significantly higher in the beta thalassemia group over the sickle cell group. Next slide. So how can we assess iron? Next slide. The relationship of liver iron to duration of chronic transfusion is quite clear. So here in a study, people's mean ferritin before they initiated transfusion was 420 around. Their peak ferritin hit over 4,000. At the time of liver biopsy, the ferritin was around 2,000. And what was shown was that there was a poor correlation between the average serum ferritin and the quantitative iron on liver biopsy. People with high ferritin and even people with high liver iron content, still overall, a lot of them had only mild to moderate inflammation and fibrosis. And the extent of liver injury was mild despite the very high iron overload. And this is in sickle cell patients again. Next slide. Liver biopsy were in patients with sickle cell anemia and chronic transfusion. And here you see a graph that shows that the ferritins versus the liver iron concentration, the dots are all over the place. This really is not a good correlation. I do not think that we can take ferritins safely, even though that's what probably most of us do, to taper iron chelation, for example. What this study concluded is that if you have a serum ferritin between 750 and 1,500, that the iron is probably okay most of the time, but you don't know when it's not. And if the serum ferritin is over 3,000, that you probably have iron overload. But again, there are going to be people where that's not the case. And do we really want to put somebody on iron chelation when they have a ferritin of 1,500 when we really don't know what their liver iron looks like? Next slide. A study of 247 patients with sickle cell looked at, well, do people with low ferritin do better or with high ferritin? And this study showed that people with low ferritins overall or low iron saturation overall have significantly lower acute painful episodes, organ failure, or mortality. And that's all good and fine, but we don't know, is this really iron overload we're talking about here, or is ferritin really a very prominent inflammatory marker or a marker of severe disease? Next slide. So how do we measure it? Even though ferritin is readily available, it's cheap, it has some prognostic value, it is an acute phase reactant, and overall, I want to make the statement that it is a poor marker for iron overload. Liver biopsy continues to be the golden standard. It is invasive, it's difficult to do, patients may not want to do it, but it accurately gives us a hepatic iron content. Next slide. As mentioned in the lecture in March, superconducting quantum interference device is one measure to measure iron overload, but it is not readily available. And to my knowledge, I think there are only 2 centers in the United States that have it, and I don't see the future in that. Next slide. However, I do see the future of non-invasive iron monitoring in MRI. And here you see an MRI of a liver that's iron overloaded over one that's not. So MRI with a T2 weighted image is a good measure, or can give us a qualitative measure of iron overload. If we combine that with the software and we do an R2 weighted image, and the software is called a FerriScan, and I think Noreen Sullivan is on or usually, at least used to be on the line. I think this is starting to be a very well-validated instrument, non-invasive way for us to quantify iron overload, and that's something that we're trying to implement, but there seems to be some reimbursement issues. But I hope this is something we're going to see in the future. Next slide. So benefits and risks associated with therapies to reduce body iron. Next line. First off, we have to think about, well, can we do something to not even get there? So avoidance of transfusion is going to be crucial unless you have a clear indication why you're transfusing a patient. Beyond that, employing red cell transfusion has been shown to reduce iron overload in chronically transfused patients, but it increases the absolute requirement for donor units. And as we've seen, the more units you're exposed to, the more likely you are to develop an alloantibody or another complication. It requires a permanent vascular access, and you may have problems with thrombosis or infection with that. You need trained personnel. Next slide. So what do we have available beyond that to get some of that iron out? What iron chelators do we have? We have deferoxamine that's been around for a long time. Deferoprone is not available in the United States, and then since 2005 we have deferoxarox or Exjade. Next slide. Deferoxamine you probably all have heard of and you all have some experience with. It's been around for 30 years. There's abundant literature documenting positive impact on survival. It has a short half-life, and therefore it has to be given over several hours at a time. So traditionally it was given 8 to 12 hours, 5 to 7 days a week with a subcutaneous infusion. So compliance, understandably, was very low, but the survival correlated with the compliance. Next line. Exjade, or the Deferoxarox, came out in 2005 and got its accelerated approval. The starting dose is 20 milligrams per kilogram. It now has a maximum dose of 40 milligrams per kilogram. It works in some, my personal experience, and that of others. It does not work in everybody. It has to be diluted in water or juice in the morning, and I really have a problem with compliance in patients. Next line. It does work, however, at the higher doses, and here you see at a lower dose we have the DFO versus the deferoxamine, and you can see that at the higher doses it can be very effective at decreasing the liver iron concentration. Next line. It does have side effects. Both of them have visual and auditory neurotoxicity. Usually that's reversible, so you just stop it. You can also have elevation of your serum creatinine, so that needs to be monitored monthly. Proteinuria. You definitely want to check your liver function tests, which can be tricky because we're talking about people that are iron overloaded and may have liver enzyme elevation due to that. People can have some abdominal discomfort with the oral form, some diarrhea and nausea. There can be hypertension and anaphylaxis. Next slide. What I do want to talk about briefly is IV deferoxamine. Because of the short half-life, is thought to have to be given over a longer time. This was a study of 27 patients that received it over 48 hours, and that was anywhere from every 2 to every 4 weeks. This was given over months, but it clearly and statistically decreased the liver iron concentration. Next line, or next slide. The side effects with anybody who's ever given that, and there are several studies where this IV form was given. A lot of them had no toxicity. There was this study by Friedman and al. Where 4 patients developed serious pulmonary syndrome with restrictive pattern. This is something that is very unusual. The rest of the patients had some autotoxicity or ophthalmologic toxicity, but that was all reversible. This is, again, completely off-label, but I, in some desperate cases, gave IV deferoxamine over 2 hours after each transfusion, and I've had no side effects and very, very good response to it. Next slide. So with that, I hope I gave you some data on indications for acute and chronic transfusions. I talked about some of the complications, such as access, infection, and immune responses, as well as iron overload. And I think we have some time for questions.
Thank you so much. We really appreciate that. It was a great talk. So we're now going to open the lines for questions. And I want to remind everybody, if you would like to ask a question, you're going to need to unmute your phone by pressing *6. And if you do have a question, I'm going to ask for you to raise your hand electronically so that your names can be called in the order that they were received. And we only have this line scheduled for about 5 more minutes, so I am going to have to end the session at that point. However, if you have further questions for Dr. Kruse-Jarres, please, her email address is up on this last slide, so I'm sure you're free to contact her if you would like to. So if you have any questions, just go ahead and raise your hand on the screen and let us know, and I will call out your name. I guess if anyone has a question and they can't get to the computer, but they do want to ask, if you want to press *6, and you can just state your name and ask your question. Okay, we have about 1 more minute.
Okay, so clear.
Or just, you gave us so much wonderful information. You've answered everyone's questions already. Maybe that's the case.
I don't know about that.
I had a question, if you have a minute.
Yes, please.
I'm calling from Calgary, Canada. We have mostly pediatric patients here. We only do simple transfusions. We really haven't instituted red cell pheresis. I'm just wondering, at larger centers, do you have an idea what most places are doing? And if it's simple, what about the issue about the post-transfusion hematocrit, and how vigorously do you follow that? Because It's always been a question in my mind.
Well, I can tell you from our center's experience, yes, we use a lot of, in the pediatric patients, we use a lot of simple transfusion if their iron overload is okay. And yes, we are trying to keep a good eye on the post-transfusion hemoglobin to not transfuse them over 10.
So how often are you bringing patients like that back? That must be the maximum 4 weeks.
Oh, well, so if people have an indication for chronic transfusion, such as an elevated TCD, yeah, we bring them back every 4 weeks.
Thanks.
Does anyone else have a question? Okay, well then thank you so much. This was really, really excellent. It was very informative, and I hope everybody was able to get a lot out of it. We had a large number of attendees on the phone, so I know that your information really was able to reach a large audience. So I just want to remind everybody that our next webinar will take place on Thursday, August 25th. And the name of the webinar is Bone Marrow and Stem Cell Transplant Program, a Retreat for Families and Patients. So if you have any questions, please feel free to contact Shay Pope, and her email address is spope@cdc.gov. And just as a reminder for everyone, the recorded webinars are available for viewing and listening if there was one that you missed. The website for that is www.scinfo.org. So it's scinfo.org. And then the recordings are under the webinars toolbar. So feel free to go and check those out if there's anything you've missed or if there are any references you want to check out.
Quick question, is it possible?
I'm sorry?
Can I just ask one quick question?
Sure, absolutely.
Is the Therascan application, is that readily available? Because I'm not familiar with it. Right, so I was not either, but we're trying to implement it. I can send you some information as to who to contact, who can give you more information about it. And she's very available and can get you all the data, and she's very instrumental in trying to help us set up the Therascan here. Great, thank you.
Yeah, this is Noreen Sullivan.
Oh, there you go.
Hi, how are you? Yes, I work for Residence Health and support the Therascan application, so I would be happy to provide any information that you need, clinical evidence. And you can reach me. I'll give you my email address. Okay. And that is my first name, Noreen, N-O-R-E-E-N-S, @resonancehealth.com.
Did you spell that? Resident?
Yeah, Resonance, RESONANCE health.com.
And spell your name again?
It's Noreen. It's N-O-R-E-E-N Sullivan. And I'm based in Southern California, so I'm here in the U.S.
Great. Thanks so much.
Oh, my pleasure.
Wonderful. Well, thank you all again for participating, and we will be back here on Thursday, August 25th. Bye-bye.
Bye-bye. Thanks.